Thank you very much, and thanks very much for everyone for attending. Just before I go into my main talk, I'll try and speak up because I know it's a bit noisy here. But my background is I'm in the School of Health and Human Performance in DCU. I'm also part of Insight, the largest research-funded group in Ireland, looking at data analytics, and my particular interest is in around personal sensing for connected health and for sport. And we work with a large number of organisations, and what we're really interested in is sensing the way people move, trying to measure and understand that. And key to this, and key to many of these technologies, is about changing people's behaviour. We understand lots of problems around people with regard to health. How do we change their behaviour? So basically this is about a project called PATHway. It's a Horizon 2020, has €5 million funding. We're 1 year into a 4-year project. And what we're attempting to do is to address the issues around people not exercising during cardiovascular disease rehabilitation. And we want to find a technological solution to support them. So, some of the problems that we have at the background is that up to 40% of people, or there's up to 40% of premature deaths caused by cardiovascular disease. And there's huge problems around a lack of functional independence when people have cardiovascular disease. And this places a great burden on the community. It costs Europe over €190 billion a year. And this is in the health service, loss of jobs. My particular interest is in addressing the premature deaths and the issues of functional independence. Cardiac rehabilitation is around exercise, smoking cessation, remembering to take your drugs, stress management, etc. My main focus and the focus of our project is around exercise. Although we address the others as well, it's mainly around exercise. And the reason for this is almost 25% of premature deaths can be alleviated by exercise. 25%. If we said that we had a drug and take the drug for that, people would do it. The interesting thing is people know they should exercise, but they don't. And why don't they exercise? Well, by the time they reach the age of having cardiovascular disease, they've been in a society that has engineered physical activity out of their lifestyle. Here, for example, is a fitness gym with an escalator to go up the stairs. Everyone's going to go in and exercise, yet everyone took the escalator. Yeah? We're programmed to be inactive. So how can we use technology to help address this? Well, to give you a bit of background to the problem is that for everyone who suffers a heart condition, what they would usually do is that they've had the event, they go to hospital, and they may have a stent put in, and then they have some rehabilitation, and then they go as an outpatient for maybe 12 weeks, returning 3 times a week to the hospital and having one cardiac nurse to 12 patients, very personalised rehabilitation program. The problem is then when they leave, only 10% of the people go to community-based programs, and then half of them drop out. And this is a rehabilitation program run in my own university where we have 600 patient visits a week to exercise for conditions such as cardiovascular disease, cancer and diabetes. So we understand why people enjoy community-based programs, but not enough people come along. So what are the barriers to this? Generally, there's not enough programs out there dedicated to cardiovascular disease rehabilitation. And as I said, we run such programs and they need a lot of attention to the patient. So how can we replicate that? What are the other barriers? Well, some of the other barriers, for example, are distance. People are too busy. Some people, even as grandparents, are the main caregiver during the day and don't feel they have enough time to exercise. Others feel isolated and they don't have the support of others around them. And believe it or not, some people feel that everyone else is going to be able to do more in the exercise program than they are. And we have to give people confidence. So what we have developed is a technological approach to this. And the two key things here are changing people's behavior and helping them to self-manage their own condition. There's lots of research out there now that shows that the more credence you put on people to self-manage their own condition, the more likely they are to change their behavior, rather than just delivering services and technology that encourage them to come along to the hospital rather than managing their own condition. So, someone suffers an event at home, they go to hospital, and they would get some level of treatment. They'll have the rehabilitation, as I said. Now they're going to go home, and we want to help them. So we have developed a technology which has a number of components to it. In all the cases, we're trying to replicate what happens in a good community-based program. So what happens is they're introduced to this technology in the hospital. And what it consists of is, for example, a Microsoft Connect, and it will measure them doing their physical activity at home, measure them doing their exercise. They'll have an avatar who will show them what exercises to do, but they designed their own exercise program with a cardiac nurse. The avatar acts as an interface. So the avatar also asks questions such as, have you enjoyed this exercise program? Is it too difficult for you? The technology as well, which has to use a Microsoft Connect and has to use a wrist monitor to measure heart rate, but not the other technologies, means that as someone's exercising, the technology can clearly see what they're doing. It counts the repetitions as they're doing it. It measures the heart rate as they're doing it. And if, for example, they can't keep up with the exercise program, it automatically adjusts the exercise program to make it easier for them so they don't have a sense of failure. Because that's really important to change people's behavior. The second thing from a health perspective is if the heart rate is too high, it automatically reduces the amount of intensity of exercise, so it brings them back into the target heart rate zone. And if they stay outside that zone, because of the medication perhaps, or an interaction with the medication, it tells them to stop exercising. But the main thing it does is to encourage them to exercise on an ongoing basis. As I said, we also have a heart rate monitor, and we also have a blood pressure monitor and a 4-lead ECG for those people who need it. But we don't want to encourage them to become reliant on this technology. But if they feel they need that for the first few months of exercising, then there's built-in systems that will measure what they're doing and tell them if it's safe for them to exercise or not exercise. But we don't want them just exercising at home, we want them to exercise outside as well. So the system is designed to recommend exercise for outside. So we can encourage them to get outside of their home and not be homebound. Another key element of this, beyond behavioural change, is peer support. The reason why community-based programs do work when people stay with them is because of the connectivity they have with other people when they're there. So with this program, what they can do, if they choose, is to socially link with up to 3 other people, plan their exercise session and exercise together in their own home, remotely with each other, so they can talk to each other. And the talking isn't around, well, aren't we great at exercising, although that can be motivated. It's very often around problems. I don't feel well today. Should I exercise? I didn't take my medication yesterday. And other people, because they've been through the program, can socially support them. Because the biggest thing we found when we asked people who come along to our community-based program, what do you enjoy most about it? In a great Irish tradition, the vast majority said a cup of tea and a chat at the end. And that's what the technology has to facilitate, other than giving people a cup of tea. We then take all of that data. Imagine we're sensing how much they move. We're sensing when they're outside, how many steps they're taking. We're sensing whether they're adhering to the goals that they set. We're sensing whether they've done the exercises correctly. And we're also giving them behavioural change messages. And these messages are tailored to them as individuals based on questionnaires at the start. So we've got this wealth of information that we want to take. We want to mine, we're a center of data analytics, and we want to develop decision support systems that automatically change the exercise to make it more likely that they'll adhere to the exercise, or change the behavioural change messages that increases the likelihood that they're going to adhere to the program. So envisage that we have 10,000 people across Europe and we're collecting this amount of data for 6 months, a year, 2 years. That's more data on cardiovascular disease than anyone will ever have. And we can mine that to truly understand behavioural change. Remember, all of you know that you should exercise. How many of you adhere to 10,000 steps a day? How many go for 3 50-minute bouts of intense exercise a week? You all know you should, not many people do. So we'll take this information, we feed it back to the patients to motivate them to adjust their exercises. We feed it to the GPs who want to access it in a very summarized version. Are they exercising or not, basically? And then to the cardiac specialists, the same level of information, and if necessary, we can send ECG to them when they're exercising. And there's a standard test built in once a month that everyone does, so that we can track the true change in exercise adherence and functional capacity. So there's a whole data modeling and feedback systems for changing the exercise and the information that we give to people. And we want to make this facilitate crowd level researching as well. We don't just have an exercise class, so there's an exercise class with a warm-up aerobic session and a warm-down that you exercise along with an avatar to. We're also developing games, okay? We don't know whether that age group will enjoy games. We're talking about an average of 60-year-olds. But interestingly, we did a large number of surveys, I believe passionately, that technology must be patient-driven. So we spent a lot of time in the first year. We had over 300 questionnaires with patients, 30 interviews lasting over an hour, one-on-one with patients, 25 with clinicians. And it was interesting that just as one snapshot, will they use this technology? They said they're interested in it, but 75%, these were 60-year-olds on average, 75% of them access the internet every day, and they feel comfortable with using mobile phones and computers and the internet. So, what are the key driving factors? Number one, behavioural change. We have specialists in the area of behavioural change, and I personally believe one of the challenges around technologies is people just giving information without understanding how you change people's behaviour. Second thing is to empower people to self-manage their conditions, so they're making the decisions. What exercises will I do? How often will I do it? And we encourage them to reach the targeted standards. Societal support, so peer support. We link people together so they act to be experts in their own area and encouraging each other to exercise. And finally, that technology is a facilitator, not a driver. You need to understand the problem, how to make that change, and select your technology to be able to facilitate that. Now, I wouldn't be naive. We need this to be commercialized at the end. Why? Because even though we believe we've got an understanding of what the patients want, hospitals already want it. The Mater and Private, the Mater and Beaumont and KU Leuven in Belgium are going to trial it for us. They've already bought into it. We are in contact with the Health Service Executive, with Anya Carroll and Peter Connolly, and they've bought into the idea of it. They're on our advisory board, in fact. And we have health economics analysis going to be done on it. They're part of our group as well. But none of them are going to roll out the system as a commercial entity. It's not their role. We have to bring commercial groups into this. We have to attract them so that they see there's a way of making money out of this. And this will be done in a number of ways. One way in which we'll do it is with PATHway, with a large number of people who would utilize it. Remember, these people have come very close to death. It's a life-changing situation, and we believe that either they or their families will pay for something that's not too expensive. In addition to that, the same technology can be rolled out to other disease conditions, just changing the behavioural change messages and potentially changing the exercises, but using the exact same platforms. In addition to this, it can be used for general health, for those people who want this type of approach to exercise at home. And finally, it can be used for clinical trials, rather than people going into a hospital or a trial centre and having physical tests carried out on them. They could be at home using this technology and using the sensors to sense the information, because we have the capability of drawing down electronic health records and writing to electronic health records as well, where the patient and the hospital give permission. That's a key component of the Pathway collaboration, as well as that we have expertise in this area. So basically, this is our vision of Pathway. Pathway stands for Physical Activity Towards Health, and it's our vision in relation to rehabilitation from cardiovascular disease. Thank you very much.